So, good morning, dear colleagues. I will present a case from live in a box case from our hospital. This 79-year-old male patient was referred to us with dyspnea 3, transthoracic echo. There was a severe mitral regurgitation and severe tricuspid regurgitation. The patient underwent 3 years ago a surgical aortic valve replacement. He has a permanent atrial fibrillation, no coronary artery disease, and during the right heart catheterization, there was a systolic pulmonary pressure of 55 millimeters of mercury. So, next step was TEER screening to assess the pathology of the mitral valve. So, I'm going to show you some videos and a 3D also. So the main pathology is prolapse of the AML in A2 segment, also a tethering of the posterior leaflet. We have biatrial dilatation and so some functional components as well, and thus resulting in an eccentric jet towards the free wall of the atria. Consider the anatomy is suitable for TEER. So we had a discussion in our heart team with our surgeons. The patient was 79 years old. We had a previous cardiac surgery, symptomatic severe MR. The valve anatomy was favorable, and so we had also an elevated pulmonary pressure and a Euroscore of 6.1, which is pretty high. And we decided to proceed with TEER. And that's the live in a box. So that's the signal for our pulmonary vein with some systolic reversal. Again, some 3D images of the valve. The aorta is at 6 o'clock. So after puncturing the femoral vein, we're proceeding with the transseptal punction. We opted for a superior and posterior position to gain some height. And that's our first device. So the length of the posterior leaflet was measured at 7 millimeters. So we opted for an NTW device. And the primary jet was central. So our first attempt was to grasp the A2P2 position. So there's some orientation in 3D images. We're at 12.6 position. We're happy with that. So I'm moving forward. And again. So we are under the valve and we are ready to grasp, but we see that in our intracommissular view, our trajectory is pretty medial. So first we want to readjust the device so that we have a better trajectory, and that was possible. And then we proceed with the grasping. Because of the tethering, the grasping of the posterior leaflet was a little bit tricky, but after some attempts we could grasp it with enough tissue inside. And that's the result. It's a stable position, and I'm going to show you some color as well. So we still have some significant jet coming medial to the already implanted device, so our thought was either leave it there and try a second one medially, which is not that good for our imager, or remove it. So we checked first of all the gradient, which was under 4. We also performed some 3D images. We had a nice tissue bridge, so we decided to leave it there and proceed with a second device medially to the first one to eliminate the medial jet. We measured again after releasing the device the mean pressure. It was at 1.9 millimeters of mercury. We were pretty happy with that, so we proceeded with the second NTW device. Grasping this time was much easier, so we opted for a position really close and parallel to the first device to eliminate the jet, but we encountered a problem. So we practically, every time we were grasping really near to the first device, we were practically splitting the jet. So we still had some significant jet coming medial to our second device. So we decided to move it a little bit far from the first device and thus obtaining a good result. So we eliminated every jet coming medial to the second device, but still had some jet between the two devices, but that wasn't that significant. Again, after releasing the second device, we're checking our tissue bridge, was pretty satisfying. The already described jet between the two devices. The 3D error was 0.1, so we had a reduction practically to mild regurgitation, stable device position. Our mean pressure was measured, I guess, at 2, we'll see. No, is 4 millimeters of mercury, pretty acceptable. So we ended the procedure there, we were pretty happy. And that's the post-procedural echo before discharging the patient from our hospital. 2 days later, stable position of both clips. There was a mean pressure again measured at 4.2 millimeters of mercury, so no significant stenosis, no residual big regurgitation. Still a preserved alpha function, no pericardial effusion, so we were pretty happy with the result and we could discharge the patient. Thank you for your attention. I'm happy to take questions.
Any opinion about the space between the two clips? I think there's a lot of attention paid. I don't know if it's a kind of a cosmetic thing we don't like, or you think it's a real hemodynamic effect. Does it matter? Will some of them progressively close?
I think that it's not really important. I think that we aim to decrease the MR, and I don't think that the distance between the two clips is important. It might be important in several conditions when you have a gradient issue. If the clips are very close, the risk for to have a gradient is less. And this is the only issue that I say you need to put them very close. But I think that this case shows that you can plan whatever you want before a clip. But then you go to the procedure, sometimes you do not really plan to put one in the middle and add another one very medial, right? It was not your plan. But you put the first one, you had some issues because there was a lot of tension on the system. You had a lot of plus because you were auto-hugger. And then you could not grasp, and then you release the plus, and you grasped when you didn't have a plus, right? There was a plus, yeah, but you released it because there was a lot of tension, and then you get a grasp. You say, okay, I get a good grasp. I don't really want to lose it, so I add another one medially. So this is how clips in the real world really happen.
Exactly, and this is what we were aiming when we decided to show this live in a box, because it's our we were thinking about what should we go for a strategy for one clip, or should you do it any differently? Would you start with a strategy of two clips? You have a small on the smaller side posterior leaflet, so.
Right. I think that
or maybe we should use a different device. should we use a different device, like less traumatic?
So this is a big question. We do not really know. I think that choosing the NTW was a good thing. I don't think the XTW is good for this functional combined thing. Pascal could give you also a good result. And I always go to the middle of the valve and see what happens. Sometimes you go in the middle of the valve, you get excellent result. And if I don't get an excellent result, but I have a good grasp in the middle, and I have a good Tushy bridge, and I have medial or lateral, I add another one. But I always go into the middle, unless I have some pathological, not functional. Since I have flail P3, I'm going to the flail. But in functional cases like this, I'm always getting to the middle of the valve, put the first one, and then reevaluate exactly as you did.
Yeah, so as General Patton used to say, this is a real war zone. Nothing goes according to the plan.
Exactly. It's a mitral clip is
Totally dynamic
a
process.
field of uncertainty.
And the whole anatomy changes, the tension changes after the first clip. So what we knew before does not really matter afterwards, right? Yes, fantastic. So we don't have any comments. We will go further with Professor Shuvy. We have an excellent presentation, tips and tricks for yellow and red.